Welcome everybody to the top 10 things for BLS providers in the 2013 protocols. I'm Brian Lilly, and before we jump into the top 10 list, let's find out where we can get our hands on a set of the protocols. We've designed the protocols in 2013 to be accessible on smartphones and other mobile devices. So if you would, go ahead and grab your smartphone and open up a browser. Point your browser towards www. That's important because we need that in there to make sure it finds the right directory, .tcad.net, and then you'll soon be able to see the TCAD homepage, and in the middle of the screen you'll see a blue bar that has a menu for several different selections, and we want to go down to the Departments selection. When you hover over Departments, you see another drop-down menu, and from that drop-down menu we want to choose Clinical. Once that is highlighted, depending on your browser and your phone, you may be able to choose either Clinical or Protocols, and either one of those will open up another window that will give us a link to the 2013 Taney County Emergency Medical Protocols. Go ahead and click on that link and it will open up a PDF document that looks something like this. Once that document has loaded, you can choose to view it right there, or depending on your phone and your browser, you may also be able to open up another window to add it to your home screen or bookmark it within that device's browser. Alright, if we've got a copy of protocols in front of us, let's go ahead with our top 10 list. Just like every top 10 list, we're going to start at number 10. Number 10 on our list is these protocols are county-wide, not just specific to TCAD. In the past, there's only been medical protocols for the ambulance district, but now, thanks to the Taney County EMS System Memorandum of Understanding, all of the departments participating in that MOU will be able to use these protocols and our medical director as their own. Number 9 on our top 10 list is the county medical director, is Dr. Costello. He has an introductory message for you on page 7 of the protocols. He'd also love to hear from you at tcostello@tcad.net. He's currently an ED physician at Cox Medical Center Branson. Prior to that, he was the chief resident of his emergency residency program at St. Luke's in Bethlehem, Pennsylvania. In addition, he is also a U.S. Navy flight surgeon and has received the Naval Commendation Medal as well as the Global War on Terror Expedition Medal. So, if you're in the ER, say hi. Otherwise, drop him a line with any comments or questions. Coming to number 8 on the countdown, we see that the first responder can do a large variety of life-saving treatments within the scope of practice provided within the protocols. On page 8, we can see several things that we're used to seeing for the first responder. However, we also see something pretty new. Number 8 says the assisting of a patient with the self-administration of aspirin for suspected myocardial infarction. What this means is that the first responder can now help a chest pain patient self-administer their own aspirin. This is aspirin that is at their location or in their residence that they already had. This does not mean, however, that the first responder can grab a bottle of aspirin out of their medicine cabinet and head off to that chest pain call that they just got paged for. Only for use of the patient's own aspirin. Number 7 on our top 10 list, the primary and secondary surveys should be conducted for all patients. We'll find notes about this on page 11, 12, and 13. If you look on page 11, you see several things you're used to seeing: the airway, breathing, circulation, and a couple of new ones. The D and the E standing for disability and exposure/environmental. So now we have a new mnemonic, A, B, C, D, E, and you can read more about that on page 11. Going to page 12, you see that everything's in italics. This is because it is a pediatric section. Anytime you come across an italicized segment in this document, it means it refers to a pediatric patient. Usually, this is a patient ages 8 or less, but it may also mean a patient older than 8 but has developmental issues that would put them in a pediatric category for that chief complaint. On page 13, we see the secondary survey. A few more mnemonics that we sometimes forget at 3 or 4 in the morning. The OPQRST and sample history are all spelled out for you there. It also talks about a complete set of vital signs, being pulse, respiration, lung sounds, blood pressure, and pulse oximetry if it's available to the first responder. Moving on to number 6 in the countdown, smoke and carbon monoxide exposure patients must be closely monitored. The details for this are found on page 44 of the protocols. You'll see a long list of the symptoms that may indicate carbon monoxide poisoning. A lot of these are very, very clear and easy to spot. However, there are instances where somebody may have symptoms for a short period of time. And the reason why we bring this up is because firefighters, first responders, are probably going to be the ones that will see those first. On a large fire scene, as you know, the EMS crew may be quite a ways off in a line behind a few tankers. So the firefighters may see these patients long before we do. Even if somebody is not showing these severe symptoms, they may have had them prior to arrival and they've resolved. So we have a note there on number 4. Any person who has had any of these above signs and symptoms but then becomes asymptomatic or better following on-scene treatment should still be transported for evaluation and observation. We can do this really easily because all EMS transport units in Taney County now have LifePak 15s that are able to do carbon monoxide monitoring. Number 5 on our countdown. Patient restraint practices have changed and should be reviewed frequently. And we can find this protocol on page 87. You know, when I was in paramedic school, I was taught that chemical restraint or physical restraint of a combative patient should be titrated to provider comfort. Basically meaning if you're having a hard time with somebody, you could restrain them. But times have changed. Missouri law and current practice in other places around the nation no longer provide for that kind of treatment of people. Thus, we see the contraindications. Patients who are alert and oriented, aware of their condition, and capable of understanding the consequences of their refusal is entitled to refuse treatment. They can't be restrained or treated against their will. After all, it's the United States, and people are allowed to make a bad decision about their medical care if they so choose. Secondly, patients may only be restrained by medical providers for medically necessary care and interventions, and not solely for provider safety or preference. That can only be... Okay, number 4 on our top 10 list. Triaging of trauma patients is important and will be practiced on all patients monthly. We see this outlined first on page 10. When we turn to page 10, we see there on number 2 that providers will practice tagging patients with triage tags on the second Monday of every month. So as a first responder, if you're showing up to a single patient scene on the second Monday of every month, don't be surprised to see a triage tag being pulled out and put on that patient. It's simply so that providers can become used to using these tags, and then when the quote big one hits, we'll all be a little bit better off. Later on in the document of the protocols, you see in the appendix, pages 105, 106, and 107, the triaging algorithms. On page 105, the medical patient triage, or MESI algorithm, is going to be used for situations such as the evacuation of a nursing home, a lot of sick people who need to be transported away from an area, and we have to create some kind of protocol for how quickly to transport them. On page 106, you'll see the START method for assessing the respirations, pulse, and mentation of a trauma patient, and then triaging them appropriately. And then on page 107, you'll see the jump start algorithm for our pediatric trauma patients. Moving right along to number 3, spinal motion restriction protocols have changed to allow for greater flexibility. I'm sure we can all remember the recent past where we showed up on a motor vehicle accident or some other form of trauma, and everybody on that scene was getting backboarded. I've seen it. You've probably seen it too. The new algorithm that's presented on page 48 allows for a decision tree that the provider can use to decide whether or not somebody actually needs spinal motion restriction, because this doesn't necessarily benefit everyone simply because they were in a motor vehicle accident or other trauma. As you guys know, spine boards are not comfortable. So let's figure out if there are actual indications for spinal immobilization. This comes directly from the pre-hospital trauma life support curriculum. It looks a little bit intimidating at first, but I recommend that somebody think of the last motor vehicle collision that they worked and work their way through this decision algorithm based on what they remember of the patient's chief complaints and what they found on physical exam. Again, it's easy to get lost in this if you make it complicated, but the overall thought here is that if you think somebody really needs spinal immobilization, we have a statement right there in the middle page. Use clinical judgment. If in doubt, immobilize, and you and the patient will probably be better off by trusting your gut. Number 2 on our top 10 list, chest discomfort is treated with the 5-10-10 rule and pit crew. You can find this on page 17 and 18. On page 17, you'll find the overall goals of chest pain management. It means aspirin within 5 minutes, nitroglycerin within 10 minutes, and a full 12-lead ECG within 10 minutes of patient contact. This seems like it's easy, but on complicated patients with a lot of complaints in addition to chest discomfort, it may not be so easy. So what we've developed is a chest pain pit crew model, and we have some roles specific for the first responder that can help save valuable time. You can see in the upper right hand corner of page 18 that the first responder can provide several support functions to save time and get the patient definitive care quickly. Providing oxygen, getting an initial assessment and vitals, and then providing that hand-down report to the transporting paramedic quickly. Helping to place those ECG leads, and then, once ALS care has been initiated, going throughout the residence or the location to gather medications or lists or any belongings that the patient may want to prepare them for transport. We're finally at number 1 on the top 10 list. Cardiocerebral resuscitation and pit crew practices are the treatment for all adults in cardiac arrest. If you've been in the Taney County EMS system for a while, you know that in 2011 and 2012, our providers were given the choice of providing CPR or CCR to adults experiencing cardiac arrest. We had resounding success, great save rates with CCR, and Dr. Costello has chosen to do CCR for all adults in cardiac arrest. This is laid out for us on 2 different pages. First, let's look at page 21. On page 21, we'll see one of the roles that a first responder is likely to fulfill, the compressor. The compressor is going to perform 200 continuous chest compressions, and on compression number 170, announce to the team leader that they have arrived at 170, and as they continue those compressions towards number 200, that team leader will then start charging the monitor so that the shock can be ready as soon as that 200th chest compression is given. After the shock is given, there will be a compressor on deck immediately jumping into the compressor roll and beginning another set of 200 chest compressions. So the first responder may find themselves in that compressor or compressor on deck roll very quickly in the first few moments of a cardiac arrest. If a first responder is arriving a little bit later, they may be asked to stay in the staging area. Don't take this personally if you're asked to stay in a hallway or another area immediately outside of the pit crew. It's really no different than a firefighter operating a tanker within a tanker shuttle line. We need you at the scene, just not right at this moment. So we're going to keep you in staging. Now, turning to page 22, we look to the right-hand side of the page to see some notes. There's several notes about cardiocerebral resuscitation quality and what makes for good chest compressions, not so good chest compressions, as well as other things that we want to think about during a resuscitation. Everyone, I want to thank you for staying with me through this video. If you have any questions or comments, please feel free to contact me with the information on the screen. Thanks, and be safe out there.